Everyone, my name is Howard Rowley. I'm the Neuro track head, and I'm just going to introduce the session. We have a terrific set of speakers today for RC 705, non-traumatic neuro emergencies. We'll take an hour and a half and take a look at three areas. Pat Tursky will start us out today with a review of CNS hemorrhage, non-traumatic hemorrhage. Pat?
Thank you very much, Howard. My goals are today to review the differential diagnosis of intracranial hemorrhage based on its presentation, imaging characteristics, and location, to recognize the variable appearance of hemorrhage on both CT and MR, and to identify the complications of hemorrhage. Spontaneous intracranial hemorrhage is divided into primary intracranial hemorrhage, which is typically due to hypertension and amyloid angiopathy, and secondary intracranial hemorrhage due to aneurysms, AVMs, hemorrhagic transformation of infarcts, coagulopathy, venous thrombosis, neoplasms, and vasculitis. As you can see, hypertension and aneurysms make up the majority of spontaneous intracranial hemorrhage. Hypertension produces arteriolar degeneration. And the arterioles are the point where the arteries have their termination into the transition zone between the high-pressure arteries and the low-pressure capillaries. So it's not too surprising that the arterioles would be the site of the most injury with hypertension. The arterioles can undergo sclerosis, which then leads to lacunar infarcts, or there can be some dilatation of the arterioles. This is due to deposition of collagen and lipid in the arteriolar walls. The smooth muscle cells are lost, and this results in a fusiform dilatation of the arterioles. This fusiform dilatation was noted many years ago and was termed by the neuropathologists at the time as Charcot-Bouchard aneurysms. And this is a patient with a hypertensive hemorrhage, and you can see a Charcot-Bouchard aneurysm here in the basal ganglia region. So these are some of the hallmarks of hypertensive hemorrhage. So hypertensive hemorrhages have several typical locations, the putamen being the most common location, followed by the thalamus, the pons, and the posterior fossa or cerebellum. The hemorrhages in the posterior fossa are particularly dangerous ones because there can be a rapid compression of the brainstem. And typically when you see a posterior fossa hemorrhage, this would be a neurosurgical emergency. Many of these patients need to have neurosurgical decompression. Patients who have a large volume hemorrhage, who are elderly, these have a very poor prognosis. And hemorrhages in the posterior fossa or intraventricular extension of the hemorrhage also have a very poor prognosis. CT plays a very critical role in the evaluation of hypertensive hemorrhage. And as you've heard many times at this meeting, the spot sign can be a very valuable finding in these patients. This is a slide courtesy of my colleague Howard, who gave the introduction. And as you can see, this is a typical hypertensive hemorrhage here in the sort of posterior aspect of the putamen. We can see the spot sign along the medial aspect of the hematoma. And then over time, we can see some extravasation of contrast from what is thought to be the the small aneurysms associated with these, Charcot-Bouchard aneurysms. And then we can see the expansion of the hematoma a few hours later. So when one sees this sort of observation, this is an indication that these patients are at very high risk for expansion of the hematoma. About 30% of the patients with hypertensive hemorrhages will have a spot sign, and of these, approximately 75% will go on to hematoma expansion. So this is a very high risk situation for these patients. This is another example where we can see extravasation of contrast material during the CTA. This patient presents with a large basal ganglia hemorrhage. We can see some variations in the density of the hematoma as there is some unclotted blood more inferiorly. Extravasation of contrast along that area of reduced attenuation, which indicates non-clotted blood. And this is a very important feature too, and one that really needs to have to be in your consideration. That is to obtain a delayed post-contrast scan after the CTA, which in this case shows very nicely that there's active extravasation at other locations and contrast pooling related to the extravasation. This patient went on to emergency decompression of the hematoma. You can see some residual hemosiderin here along the cleft of the resected hematoma. And if you look closely, you can see some areas of microhemorrhage, and microhemorrhages are a finding that can be seen centrally in patients with hypertension. These types of hematomas tend to dissect along the white matter, and so even though this patient had a very massive hemorrhage, the patient has undergone rehabilitation and is actually recovering quite nicely because you can see much of the overlying cortex is intact. Let's talk a little bit about the evolution of hematoma. The hematoma on CT is increased attenuation due to clot retraction, fibrin, platelets, and cells. Typically, a hematoma will have Hounsfield units between 50 and 60, and approximately 1.5 Hounsfield units per day will decrease as the hematoma absorbs water and there's a reduction in the attenuation due to this hydration. So if we look at this hematoma, we can see that over time there's a little bit of edema that forms around the hematoma. There's more water that comes into the hematoma with the reduction in the attenuation. And then after several months, we can see that there's just a small area of reduced attenuation. Keep in mind, though, that as these hematomas evolve, that there will be some breakdown of the blood-brain barrier around the edges of the hematoma. This rim enhancement appears in about 1 week and will persist for 8 to 12 weeks. Hematoma evolution on MR is much more complicated, as you know. Initially, the blood starts out as oxyhemoglobin, which is not paramagnetic. It's intense to brain tissue on T1 and slightly increased in signal intensity on T2. It then undergoes some degradation to deoxyhemoglobin, which is low signal intensity on T1 and T2. And then approximately 48 hours later, you begin to form methemoglobin, which is initially high signal intensity on T1 and low signal intensity on T2. But after several days, you'll have high signal intensity on both T1 and T2 weighted images. This then goes on to the formation of iron storage, which is in the form of hemosiderin and ferritin, and you'll get a sort of hemosiderin ring around the hematoma, followed by a hemosiderin cleft. This is the typical sort of appearance for deoxyhemoglobin in the relatively acute or subacute phase, and we can see relatively slight decreased signal intensity on T1 and low signal intensity on T2, flare, T2 star, and on the diffusion weighted image you get a T2 black through. After a few days, you have conversion to methemoglobin, which is bright in signal intensity on T1 and T2, and also bright in signal intensity on the T2 flare, because T2 flare has a T1 component to it. And also you can see the bright signal intensity on the diffusion weighted image, which can be sometimes confusing if you have, say, a subacute infarct and you're trying to determine whether it's got hemorrhage or whether it's a subacute infarct. So you have to keep in mind that these hematomas will be bright on the diffusion weighted images, and you'll have this bright signal intensity on the diffusion weighted images, which can be sometimes confusing with an area of infarction. So let's move on to coagulopathy. This is a patient who has hepatic coagulopathy. We can see that there's this area of hemorrhage here within the basal ganglia, which has a couple of different components to it. A little area of serum collecting above the area of the hematoma. But when we look at the perfusion-weighted images, there's a large area of reduced perfusion surrounding this hematoma. So the impact of the hematoma on the perfusion to that hemisphere is much greater than one would anticipate. If we look at this hematoma a few days later, we can see the conversion to methemoglobin again with the bright signal intensity on T1 and T2, and again the bright signal intensity on the diffusion-weighted image. But there's this very large and very extensive edema halo around this hematoma. And this represents an area where there is some potential for the brain to be injured if the patients are treated with very aggressive therapy for their hypertension. Some people believe that if you lower the blood pressure too rapidly, this area, this almost like penumbra around the hematoma, is at risk, and so the patients who have their blood pressure lowered too quickly can have hypoperfusion to this area of edema surrounding the hematoma. So this is not just an incidental sort of finding. This actually indicates additional tissue at risk due to the compression from the edema. Again, with coagulopathies, you will have these fluid levels, and so when you see these fluid levels, there's a need to rapidly improve the patient's coagulation status, and neurosurgical consultation should be considered. Let's move on to cerebral amyloid angiopathy. Cerebral amyloid angiopathy accounts for about 20% of the spontaneous hemorrhages in the elderly. This is due to amyloid deposition in the arteriolar wall and in the leptomeningeal vessels. There are a number of clinical criteria that are used to make the diagnosis of cerebral amyloid angiopathy. Typically, these are patients who are over 55 years in age. They have multiple microbleeds, or lobar hemorrhages or convexity subarachnoid hemorrhage, which is not explained by other reasons. Cerebral amyloid angiopathy coexists with Alzheimer's disease and other dementias in 20 to 30% of patients. So this is a typical example of cerebral amyloid angiopathy. We can see this lobar hemorrhage here within the temporal lobe. And on the T2 star weighted images, there are multiple microbleeds here scattered throughout the posterior temporal and occipital regions. And here on the T2 weighted images, again, we have that sort of T2 black through on the ADC map and a bright signal intensity here on the diffusion weighted images. So you can see how this could be a very confusing appearance on the diffusion weighted images and ADC map if you didn't have additional confirming information either from CT or from other MR pulse sequences. There is a relatively uncommon type of amyloid angiopathy called inflammatory cerebral angiopathy. And this is an autoimmune response to beta amyloid. And what happens is that you develop a vasculitis, much like a autoimmune vasculitis, and you'll have edema, enhancement of the leptomeninges, areas of edema, and these microhemorrhages. And so these patients benefit from steroid therapy and much more aggressive immunotherapy rather than just, say, antihypertensive therapy. So this can mimic PRESS, and just keep in mind that these patients with amyloid angiopathy can have this inflammatory component. Now, this is a very important case here because oftentimes you'll see these small convexity hemorrhages in patients, and you won't really have a good idea of what it's from. And with the T2 star weighted images, one can certainly get a sense that there are these microhemorrhages and would lead you towards the diagnosis of amyloid angiopathy. But what you don't realize is that these are small microhemorrhages in the leptomeninges. And so this is a patient who comes back 7 years later, and we can see that there's siderosis here in the superficial leptomeninges. And on the T2 star weighted image, it's really quite easy to see, but on the susceptibility weighted image, we can see much greater signal loss related to the leptomeningeal siderosis. So keep in mind that amyloid also involves the leptomeninges and can produce this leptomeningeal siderosis. Also, one of the more recent advances in susceptibility weighted imaging is the use of both phase images and magnitude images. This was introduced by Mark Hakey many years ago. You take the phase image, multiply it by the magnitude image, and you get this much more sensitive susceptibility weighted image. And the susceptibility weighted images are much more able to identify these microhemorrhages when compared to the T2 star weighted images. So what are the other causes of microhemorrhages? Well, we talked about hypertension being more central in its location of microhemorrhages. You can certainly have multiple cavernomas. After radiation therapy, you can have multiple small hemorrhages. These are thought to be either radiation-induced telangiectasias or little cavernomas. Certainly, metastatic disease can present with multiple small areas of reduced signal intensity on susceptibility-weighted imaging. Typically melanoma, renal cell, but there are many others. And then rarely, CADASIL, since that is a microangiopathic disease that involves the arterioles, you can also see these small microbleeds in patients with CADASIL. So let's move on to the other big category of hemorrhage, and that is subarachnoid hemorrhage due to aneurysms. This is the typical situation of a 53-year-old patient who presents with the worst headache of her life. We can see that there is diffuse subarachnoid blood throughout the basal cisterns around the perimesencephalic cisterns. Here is a superior hypophyseal artery aneurysm with this bleb along the very apex of the aneurysm. These types of morphologic configurations are thought to be of higher risk. There are several categories of hemorrhage that you will hear discussed in regard to the sort of staging of these patients with subarachnoid hemorrhage. The first is the Fisher grading scale of subarachnoid hemorrhage. The Fisher grading scale goes from 1 to 4, where there's no blood on the detectable by CT. Grade 2 is more this diffuse type subarachnoid hemorrhage. Grade 3 is where there is a small clot in the subarachnoid space and diffuse hemorrhage. And grade 4 is there is parenchymal hemorrhage and intraventricular hemorrhage. You'll also hear the neurosurgeons and endovascular therapists talk about the Hunt and Hess grading scale for subarachnoid hemorrhage. And this ranges from asymptomatic patients with just mild headache or moderate headache all the way to confusion, stupor, and coma. So I just wanted to introduce you to these two types of sort of descriptions of subarachnoid hemorrhage, which you'll hear very frequently in the discussion of these patients. This is a patient who presented after having a previous episode of subarachnoid hemorrhage and then was transferred into our institution. We can see there's a small amount of hemorrhage here within the cistern of the middle cerebral artery. And on the FLAIR image, there is a little bit of increased signal intensity along the middle cerebral artery, but also a little bit of increased signal intensity, which we can't appreciate on the CT, but can appreciate on the FLAIR MR. And we've known for many years that FLAIR is very sensitive to blood products in the subarachnoid space. But unfortunately, it's not very specific. And so other entities such as meningitis, propofol, high oxygen content, high oxygen therapy, retained gadolinium, or artifacts due to metal in the imaging field can result in incomplete suppression of the CSF and also give you this abnormal high signal intensity on FLAIR. So even though FLAIR is very sensitive, it's not very specific, and so it's very much more important to use CT as your primary evaluation method. If we go through this patient's evaluation, we can see that the patient is now a few days out from the hemorrhage, and here is the vasospasm associated with the subarachnoid hemorrhage. Typically, it takes about 3 days for the vasospasm to form. And as I mentioned, this patient had a sentinel hemorrhage a few days before transfer to our hospital, and so we can see that there is pretty severe vasospasm related to the subarachnoid hemorrhage. You may have heard at this meeting that there are some sort of new recommendations regarding the evaluation of patients with aneurysm. Villablanca from the University of California, Los Angeles, has studied about 300 patients over approximately 3 years. And what he found is that there was growth in about 18% of the aneurysms. But in the past, it was thought that only the larger aneurysms were at high risk, but he found that there was growth in the aneurysms of any size, and that if there was growth of the aneurysm, there was a 12-fold increase in the incidence of rupture. Other risk factors that he found are smoking, and if the presentation of the aneurysm size was greater than 5 millimeters. We've also known for some time that these little blebs can be a high-risk situation, and we can see here on the MRA that there's a flow jet impacting the apex, the dome of the aneurysm. And if we use techniques such as phase contrast MRA, we can see this flow jet coming into the aneurysm. This is the impact zone where there would be the highest wall shear stress and presumably the highest energy deposition, and perhaps the location of future rupture and hemorrhage. But we can also see these areas of recirculation along the lateral aspects of the aneurysm, which indicate areas of low wall shear stress. And it's thought that these are the areas where the aneurysm grows because the endothelial system and the endothelial lining in these locations is not as healthy where there is this sort of recirculate flow. Okay, let's move on to perimesencephalic subarachnoid hemorrhage. This is typically venous in origin. It's thought to be due to anomalous veins in the region of the vein of Rosenthal. It simulates subarachnoid hemorrhage from a basilar tip aneurysm. However, it has a very typical location following the perimesencephalic cisterns. And typically, these patients have a benign course, although you do need to work them up pretty thoroughly to exclude an underlying aneurysm. But they rarely have vasospasm, and there's usually a pretty good correlation with the distribution of the hemorrhage in the perimesencephalic cistern and either repeat negative CTAs and DSAs or just follow-up. There's also another entity called pseudo-subarachnoid hemorrhage. This is when there is diffuse brain swelling and edema. The result is this hyperemia within the meninges. You lose the gray-white junction, you compress the sulci. And so this hyperemia in the basal meninges is slightly increased attenuation in relationship to the surrounding brain. And so this gives you the false impression of subarachnoid blood. We're going to move through vascular malformations. This accounts for about 11% of all spontaneous intracranial hemorrhage. PL vascular malformations typically are in sort of the age range from 30 to 60. 50% present with parenchymal hemorrhage. Dural fistulas, usually the hemorrhage is related to a venous ectasia. Cavernomas have central hemorrhage of variable age. And developmental venous anomalies rarely hemorrhage, but when they do, there's usually an associated cavernoma or thrombosis of the draining vein from the DVA. So here we can see this large hematoma with some intraventricular extension, this little area of enhancement along the lateral aspect of the hematoma. And on the angiogram, this close and marginal branch coming over the top, supplying this little nidus of the AVM. And this is a typical story with a 32-year-old patient, a relatively young patient with sudden onset of headache, nausea, and vomiting. This is another patient who awoke with severe headache, nausea, vomiting, and his wife noted that he was lethargic, brought him to the ED. And we can appreciate there's this large calcified area here along the lateral margin of the ventricular system, blood within the lateral ventricle, these hypertrophied, enlarged branches from the angular artery, and then this calcified nidus. And this patient has deep venous drainage, which we know is a higher risk situation for surgical management, but also can lead to, is also a high risk situation for additional hemorrhage. Moving to dural AV fistulas, usually these are associated with a venous ectasia, and this is a patient who presented with a large subarachnoid hemorrhage due to a dural fistula. And on the CTA, we can see this area of dural ectasia, venous ectasia related to the draining veins from this dural fistula. The venous ectasia, of course, this is a situation where the vein wall is dilated and it's thought to be more prone to hemorrhage. And we can see that the hemorrhage seems to surround this little area of venous ectasia. So dural AV fistulas are typically divided into four types. Type 1 and 2 are the most common. Type 1 with antegrade flow in the transverse sinus and jugular vein. Type 2 with retrograde flow. Type 3, there's usually cortical drainage, and these have a higher incidence of hemorrhage. But the ones that you will likely run into that present with significant subarachnoid hemorrhage are the ones with venous ectasia and these large dilated draining veins. Cavernomas have a fairly characteristic appearance with the hemosiderin rim and the popcorn-like methemoglobin centrally. They can be single, multiple, sporadic, or familial, and about 10 to 30% are associated with DVAs. Developmental venous anomalies are kind of interesting. They have a Medusa-like appearance, Medusa head-like appearance to the tributaries that go to the main draining vein. These are much better appreciated on the susceptibility-weighted images. On the T2 star weighted images, more and more people are finding that there are these hypodense areas in the region of the developmental venous anomaly. And these hypodense areas are not pathologically evaluated yet, but the hypothesis is that there are in fact small cavernomas which previously have not been easily identifiable that exist with many of these DVAs. And as you can see in this one, there's some associated gliosis, some alterations in cerebral blood flow, and some prolongation of the mean transit time. So even though we think of most developmental venous anomalies as being benign, there are probably a subset of developmental venous anomalies that are in the process of developing cavernomas associated with them and can alter the flow locally within the drainage field of the DVA. Moving to another category, and that is the hemorrhagic transformation of infarcts. The risk factors for hemorrhagic transformation include the presence of microhemorrhages, very low cerebral blood volume, very low ADC values, increased permeability, or a Tmax of greater than 14 seconds. And so here we can see a typical situation where there's a dense middle cerebral artery, some very subtle edema forming here in the insular cortex, some restricted diffusion on the diffusion-weighted images, and a microhemorrhage on the T2 star-weighted images. On the mean transit time, there's a large penumbra, but on the cerebral blood volume map, we can see there's an area of very low cerebral blood volume. This patient was treated with TPA, and then we could see that there is some evolution of the infarct with some hemorrhagic transformation, this area of hematoma formation here near the caudate nucleus, and areas of petechial hemorrhage around the basal ganglia. Petechial hemorrhages can be divided into types 1 and 2, where they're type 1 being no mass effect, type 2 minimal mass effect. Parenchymal hematomas can be type 1, where there's less than 30% of the infarct involved, or type 2, where more than 30% of the infarct is involved. And ECAS defines symptomatic hemorrhagic transformation as any blood that results in an NIH stroke scale increase of greater than 4. And if there's malignant edema, you may have to deal with craniectomy. So we'll just close here with venous thrombosis. This is a situation where there is patients present with severe persistent headache. Pediatric patients may have nausea, vomiting, and irritability. When there is seizures, that usually indicates extension into the cortex and venous infarction. The pathophysiology includes venous stasis, thrombosis, venous hypertension, ischemia, and infarction. And the cortical hemorrhage may be bilateral and sagittal sinus thrombosis. This is a typical situation where there's an area of hemorrhage due to propagation of the thrombus into the cortical veins. And here on the phase contrast images, sagittal sinus thrombosis, predominantly involving the anterior two-thirds of the sagittal sinus. And this patient with Crohn's disease, we can see an area of reduced attenuation on the CT scan in the region of the thalamus, no flow within the deep veins on the 2D time of flight or the phase contrast exam, and an area of hemorrhage here within the thalamic venous infarcts. You can also see propagation of thrombus into the vein of Labbé, where there is this hemorrhage within the lateral temporal lobe, secondary to the thrombus within the transverse sinus, which has then extended out into the vein of Labbé, which you can see right here, resulting in venous hypertension, hemorrhage, and surrounding edema. Another area of cortical vein thrombosis here with a patient who comes in with this enhancing area which looks like cerebritis, but on the CT you can see that there's a filling defect within the anterior sagittal sinus. Here high signal intensity on the T1 weighted images, areas of edema, and some areas of restricted diffusion. So these cortical vein thromboses can be a little tricky to pick up. So we'll just skip over vasculitis because I see I'm out of time here, but just keep in mind that vasculitis is a very difficult diagnosis to make. You sometimes can pick up some large vessel vasculitis by seeing the beating or the string of sausage appearance, but more often than not, you run into normal MRA and MRI, and this doesn't exclude vasculitis, and DSA or even leptomeningeal biopsy may be necessary. You can see the areas of vasculitis here in this patient with SLE. So thank you very much for your attention. Just remember that CT and CTA are your primary tools, that MR for amyloid angiopathy. Your differential diagnosis can be based on location, and keep in mind the hematoma evaluation for mass effect, active bleeding, and to try and identify the underlying lesion using CTA and MRA. Thank you very much.
Thanks so much, Dr. Tursky. That was really spectacular. Is Turgut Tali here yet? I know he loaded slides, it looks like. But if he's not, we're going to go a little bit out of order here with a fantastic review by Dr. Wendy Smoker from Iowa. Wendy is going to take us through some non-traumatic head and neck emergencies, so cases not to miss. Wendy, take it away.
Well, I can't say I exactly followed directions because there are some traumatic injuries here. Sorry, Howard. Anyway, it's a pleasure to be here. Thank you for inviting me. You guys are awesome. Could you turn off the light? being here at whatever time, at 5 o'clock on a Thursday afternoon. So thanks for sticking around. I'm going to talk about a variety of ENT emergencies. I'd like to thank these individuals. Oh, thanks for lending me some of the cases that I'm using today. And what I'd like you to learn from this are various traumatic and infectious orbital pathologies that can compromise vision, various neck infections that can cause airway compromise, and how these neck infections extend. Understand the patterns of extension for odontogenic infections, which of course, as you know, are very common. And finally, list the various intracranial complications of acute sinusitis and be able to identify these abnormalities. So if we talk about orbital emergencies, we have traumatic visual loss, infections, pseudotumor, subperiosteal hematomas, and CC fistulas. So first, you have to understand how we see, where the visual pathways are. So light comes in and traverses the anterior chamber, gets redirected by the lens, goes through the vitreous here, gets redirected back here on the retina, and ends up at the intraocular optic nerve, comes back along the intraorbital optic nerve, and goes through the intracanalicular portion of the optic nerve. So you need to look at this all the way through. So here we have blood in the anterior chamber. This is actually an open globe injury. The patient has markedly decreased vision. In another patient, this is rupture of the anterior chamber. And I love these parasagittal images. Sometimes you see this the best. Notice the normal anterior chamber here, 2 or 3 millimeters. And on the left side, the anterior chamber is deflated. It is ruptured. This is an open globe injury, and the patient had no light perception. You must be aware of the anterior chamber pathologies. As I said, sometimes you can see them nicely on the axial, but certainly the parasagittals going right to left really highlight these abnormalities. Someone comes in, obviously bilateral lens dislocation, light's not focused very well when the lenses are floating around in the vitreous. Here's a patient that had a BB to the globe, has no light perception, large air fluid, mostly air in the vitreous. Also notice the air in the anterior chamber. Again, no light perception. And this one, because I'm from Iowa City and Iowa's the hog capital of the world, I had to put this in here. This is a guy trying to castrate a poorly stunned pig, and he wasn't adequately stunned. And so the knife slipped and it got the guy in the globe, and I don't believe these injuries happen anywhere else in the United States other than Iowa. So this is a castration injury. Well, I don't think we have very many of those, thank God. So anyway, this is a pig knife slip, as you would. Now here's an 80-year-old with a traumatic retinal detachment, and you can certainly see this V configuration of the detached retina. So be able to recognize these as well. And then finally, in this multi-trauma patient, a younger person, you'll notice that there is in fact a bony fragment in the optic canal. On the other side, you see the normal integrity and the normal appearance to the optic canal. So you must look all the way back as far as the intracanalicular portion of the optic nerve. Now, orbital infections can be very dangerous and present a huge problem emergently, and we talk about infections in terms of preseptal and post-septal infections. Now, the preseptal are limited to cellulitis, preseptal cellulitis. But the post-septal infections can be cellulitis, subperiosteal phlegmon or abscess, or a frank orbital abscess. And the old thing where we always used to say pus buys an operation, that is no longer true. Because for many of these infections, IV antibiotics or even oral antibiotics will be adequate. And then decompression if impending if compression of the optic nerve or compression of the globe or extensive, might have to go on to surgery. So if we talk about preseptal cellulitis, this is usually in children less than 5 years of age who get periorbital induration, erythema, and tenderness. That usually results from things like trauma, skin infections, or insect bites, not usually the result of a sinus infection, as we see more in the adult. So here in this patient, we have preseptal and upper eyelid edema. The postseptal space is clear, and you can see there is no evidence of ethmoid sinus disease. Here's preseptal cellulitis in another patient. Notice the preseptal edema. And also in this patient, there's stranding of the retrobulbar fat and obvious proptosis. In this patient, there is sinus disease. It's not localized to the left. It is bilateral. Now, if you get to postseptal infections, these patients can show up with proptosis, chemosis, ophthalmoplegia, decreased vision, and these are usually due to penetrating injury or adjacent sinus or tooth infection. And the complications of these include abscess intracranially, meningitis, venous thrombosis, so the consequences can be quite severe. And here again, we use IV antibiotics unless there are compressive symptoms. So here you have an upper eyelid infection in this young man that extends into the postseptal fat above the superior rectus and the superior oblique musculature, placing the musculature and the globe inferiorly, as you can see in his image. Postseptal orbital cellulitis also occurs. Here again, you can clearly see there's proptosis on the left. There's inflammation but no abscess in the retrobulbar tissues. You can see increased density and stranding here in the retroorbital fat. And always, always check the integrity of the superior ophthalmic vein. Here it is okay. There is no clot in it, which is good, because if there is a thrombosis, this is basically a medical emergency. It can progress to cavernous sinus thrombosis. Now here is a postseptal process. This is not an abscess, it's just a phlegmon. And you can see here that there is a collection between the periorbita and the medial rectus muscle. And you can see increased density in the periorbital fat and enlargement of the adjacent extraocular muscles, indicating myositis of that medial rectus muscle. Now, sometimes you have sinusitis, sometimes you don't. Sometimes you have bony dehiscence, sometimes you don't. There are valveless veins between the sinuses and the orbits. And this is probably the situation with which you are most familiar, the postseptal subperiosteal abscess, which is a frank abscess between the periorbita and the bone. Notice there's inferior lateral displacement of orbital structures here. There's adjacent maxillary and ethmoid sinus disease, and also notice compression of the medial rectus muscle. Sometimes the extraocular muscles are compressed and it limits movement of the eyeball, and the visual acuity may be affected or eyeball motion may be painful. Now, I'm putting this in here. I don't have time to cover all of the fungal sinus infections and all their sequelae, but this is a rather innocuous appearing sinus in the ethmoids, unilateral. You see some partial opacification of the ethmoid air cells, but notice some other findings on the CT. Notice that there's dirty retrobulbar fat, okay? This is not just simple sinusitis, okay? Something's wrong here. Also, notice enlargement of the optic nerve. Now, we've looked at a number of infections, and this has not been a component. This is very, very worrisome. Notice there's proptosis, particularly on the right side. And of course, once you see the dirty retrobulbar fat, the optic nerve enlargement, the proptosis, and this innocuous appearing sinus disease, you have to go on and do optic nerve infarction. The patient was actually blind in that eye, and you can see that there is an infarct of the optic nerve. Now, orbital pseudotumor is an interesting condition. It's an inflammatory condition. It's idiopathic. We don't know the cause or any systemic disease that predisposes to this. It can be acute, subacute, or chronic. Unfortunately, there's no specific clinical or radiographic findings that make this diagnosis. So it's kind of a conundrum. We do have a, quote, classic clinical picture, which doesn't always hold true. It's rapidly developing, painful, as opposed to some other entities, ophthalmoplegia, proptosis, and chemosis. There's a very rapid and lasting response to steroid therapy, and this usually occurs in an otherwise healthy adult. Now, there's a lot of imaging findings that go along with orbital pseudotumor. But the one that we most often hang our hats on is this extraocular muscle enlargement. And you know as well as I do that we're always trying to determine, is this orbital pseudotumor or is this thyroid orbitopathy? Okay, so we're looking at the extraocular muscles, but there are a number of other findings that go along. So here in this patient you can see that there is infiltration of the retrobulbar fat. It looks dirty compared to the other side. There's clearly extraocular muscle enlargement involving the inferior medial and superior rectus muscles on this left side, and there's muscle tendon enlargement. Okay, and that is the distinguishing feature between pseudotumor and thyroid orbitopathy, which spares the tendinous insertions. So be aware of pseudotumor. You can have rapid loss of vision. Now, the other thing that you might get, involved with are these spontaneous subperiosteal hematomas. And they're very rare. It is a serious complication of trauma, but in the non-traumatic setting, it happens in people with blood dyscrasias and leukemias and entities such as those. Painful unilateral proptosis. Well, what do people with pseudotumor show up with? Painful unilateral proptosis and ophthalmoplegia. So you must be able to distinguish these. Orbital roof is most common. Children and young adults are most commonly affected because in grown-up adults, the periosteum is more adherent. So it's in a relatively younger age group. And these can be continuous with intracranial epidural hematomas. So here we have a rather large mass emanating from the orbital roof. You can see this on all three planes, and notice the inferior compression of this poor globe. It's deformed, it's malshapen, the musculature is displaced inferiorly. This is clearly it's clearly beyond the extraocular muscles, and so this clearly affects vision. Here's another one. Now, this is a very interesting history. Severe onset of proptosis and upward gaze deficit following an episode of severe vomiting. This is non-traumatic unless you consider vomiting trauma, but this is a pretty serious sequelae to a bad emesis. And so here again you see orbital roof, and it's displacing the levator palpebrae and superior rectus muscle inferiorly. Now, CC fistulas, I'm not going to spend a lot of time here. There are two types that they refer to, direct and indirect. The classic presentation is chemosis, proptosis, exophthalmos, and a bruit. Now, worrisome danger signs are intracranial hemorrhage or angiographic evidence of cortical venous shunting, which is what we look for. And there can be extremely rapid visual loss, and this is often associated with a rapidly elevated intraocular pressure. This is an emergency. So here we have a patient, clearly has a problem here. I believe this was spontaneous, and there's blood coming out of the orbit. And if you look here, there's some interesting findings. You see even the facial vein is enlarged on the left compared to the right. You see here, this cavernous sinus is like way too busy. You don't see a cavernous sinus with this many vascular structures in it in a normal patient. And then, of course, we have our perfect clue here in the parasagittal images when we see an enlarged arterialized superior ophthalmic vein coming from the cavernous sinus. And here you see multiple other venous structures in the orbit, way too large They just don't belong there. So you must be able to recognize this. This person needs immediate angiography and perhaps embolization or coils. And so here's another one. This was post-traumatic as well. I believe it was associated with a ICPC aneurysm. Now, it looks like it's isolated to the right side, but I will tell you that there is a sinus called a circular sinus that goes and connects and goes around the sella from one cavernous sinus to another. So even though the fistula may be on one side, it can appear on the other side as well. So here you clearly see a very large superior ophthalmic vein, but if you look at the other orbit, you see there's other vessels floating around in here that you normally do not see in the typical orbit. Now you have to get really worried. And when we look at the coronal views, we see both superior ophthalmic veins are enlarged, right greater than left. We see a number of large venous structures within the orbit, and even down here you see further drainage into the facial veins draining this large CC fistula. Of course, on MR, this is pretty easy. You see all these flow voids in the cavernous sinus on the right, a very large superior ophthalmic vein here, and then, of course, on the MRA, you can see the vein coming forward from this large cavernous sinus, which is pathologic. So I want to go now to neck and throat emergencies. I'm going to cover these as much as I possibly can in the time allotted. So I want to make a comment about butterfly or angled images. We scan all our patients in 0 degrees because that way we can do sagittal and coronal reconstructions. But what happens in the patients that are full of metal in their mouth, you get something that looks like this, particularly on the axial images, in which you can't see anything back here in the peripharyngeal space or the peritonsillar space. So you want to do angled images around those amalgams. So here we are in that patient at 0 degrees. You can't see anything. Here we are at plus 20 degrees and minus 20 degrees with a very good view of everything posterior to the amalgam artifact. And I'll show you the use of that. So peritonsillar abscesses can extend to the surrounding fascial spaces, unilateral bulging of the tonsil. This is what you're going to see when you're in the ER. Here's the uvula. Here's this large bulging tonsil. They say they have a hot potato voice, and these are usually incised and drained in the ER, patients placed on antibiotics, and then a tonsillectomy is scheduled for approximately 2 months later. Now here is another one. You can see this thing as it shows up in the ER. This very large peritonsillar abscess hasn't extended anywhere else. This is very simple. I&D, antibiotics, next case. Well, look at this person, 25 with diabetes, bad sore throat, comes in at 0 degrees. It's pretty hard to tell. Does he have bilateral abscesses here? So here's where those butterfly images come in. So here at plus 20 degrees, we see nice, well, not nice for him, but nice bilateral peritonsillar abscesses. They drained and incised the one on the right. They tried the left, didn't get anything, put him on antibiotics, put him on pain medicine, and sent him home. Well, he showed up a week later, worse. Now I can't swallow anything. I have trismus, and you can see this left peritonsillar abscess has significantly increased in size. They added a couple more antibiotics and scheduled him for surgery. Now, another case with a complication. This woman had had 3 bouts of peritonsillar abscesses over a fairly long period of time. They I&D'd it. They put her on antibiotics. Her pain's worse. She's got shortness of breath. And you'll notice that this infection has gone back and gone around the carotid space. The vasculature is narrowed, it's in spasm, there's edema and phlegmon around that, and if we look at the MR, you can see this has gained access to the carotid sheath. You see that there is enhancement all the way down. If you look at this coronal, this enhancement goes all the way down into the mediastinum inside the carotid sheath. So you must beware of some of these complications and be willing to follow these patients up when they're not getting any better. Retropharyngeal abscesses are no longer really life-threatening, okay? The incidence has decreased in the antibiotic era. Usually we see these in children under 6 because they're related to an abscess retropharyngeal lymph node, but we also see them in the older immunosuppressed patient, usually more male than female. So infection at a site with primary lymphatic drainage to the retropharyngeal nodes, and if you study squamous cell carcinomas of the upper aerodigestive tract and infections, we're looking at sinonasal, nasopharynx, throat, tonsil, etc. So those would be the primary sites. So here is a young person who obviously has an abscess lateral retropharyngeal node of Rouvier. Notice the spasm and the edema and pus, phlegmon around the carotid artery compared to the normal carotid on the other side. Now, a lot of times these are not related to nodes, and here is a dog bone type appearance to the retropharyngeal space. This is a retropharyngeal space abscess from MRSA, okay, methicillin resistant staph, okay. Now, sometimes they're very large, and you see in the suprahyoid neck going down to the infrahyoid neck. And what do you have to worry about? Mimics of this particular thing would be a spontaneous retropharyngeal hematoma. Now, I don't know what the cause of this one was, but it's clearly visible here on CT, and I'm thinking it might have been related to the significant anterior osteophytes of the cervical spine. I don't know for sure, but I know for sure what caused this one. This was an oops, and you don't like oopses in medicine, and this was a failed intubation. This was a post-traumatic oops, and you see a very large hematoma here on the plain radiograph of the airway anteriorly, here on CT, and of course MR. I'm not exactly sure if I could justify doing an MR on this patient. I don't think it changes the management, and I can see exactly what I want to see on the plain radiograph and CT. Okay, talking about epiglottitis and abscesses, this is an older age group than croup. H. fluenza, Haemophilus is usually the cause, and the epiglottis is swollen, and they describe it as a cherry red appearance. It's thickened, it loses its normal shape, and you have to be ready to intubate or do a tracheostomy at the earliest signs of airway compression. So here we see, even on a plain radiograph, abscess within the epiglottis full of, abscess-looking stuff. And so it kind of looks like an infected sinus. So even if you want to do plain radiographs or CT, here 45 female, sore throat, fever, headaches. This particular patient improved on antibiotics and steroids and not necessitate a trach or surgery. But this younger man did not improve, had severe sore throat, couldn't eat or drink, fever to 104 with respiratory distress, and you can see the airway is almost blocked here in this young man, and he underwent an emergent tracheostomy. Now, one comment about odontogenic infections, which are so common, they typically go to the masticator space, which makes sense, and we see this every day, and I'm sure you do too. Abscess in the lateral pterygoid muscle, abscess deep to the masseter muscle, but I put this in here to show you that the abscess in the overlying the temporalis muscle can go all the way up on the side of the head, because that's where the temporalis muscle inserts. And the fascia follows the temporalis muscle. The masticator space is up here in the suprazygomatic masticator space. So you must be very aware of that and image high enough that you can see this, and you compare that to the infratemporal fossa on the other side and the normal appearance. So here is that pus pocket growing up along the side of the head. These things go to the parapharyngeal space, as you can see here, where there's air and pus as well in the 17-year-old who had a third molar removed. Now, one comment about the mylohyoid line. This is a line on the internal aspect of the mandible, and you will see that the roots of the second and third molars are below the line. you will see that the roots of all the other teeth are above the line. So if you have an infection of an anterior tooth, you're going to have a sublingual space abscess. But if you have an infection of the second or third molar roots, which are usually the ones that get infected, you're going to have a submandibular space abscess. So you know where to look. You actually know where to look. So here is a sublingual space abscess from an anterior tooth, periapical abscess. Here is a large submandibular space abscess. Notice that there's myositis of the platysma muscle compared to the normal side. There is also significant fat stranding and edema. If we look at the coronal and sagittal, we can see more of the same. We can see this is oozing out here on his face. I don't know, maybe he didn't have a mirror. I don't know why he couldn't see this till now. But you always want to look at your bone windows. You know what teeth are involved. So here you see these periapical abscesses involving the posterior molars. The teeth are sort of floating around in the sockets. Now, Ludwig angina is usually odontogenic, 90%, and it's usually bilateral sublingual and submandibular space infection. It's not an abscess. So you want to look to see what's the airway look like. Are there gas-forming organisms? Is there evidence of dental infection? And are there any abscesses you can drain? So here is phlegmon in the sublingual space, phlegmon in the submandibular space, but no abscess with gas. Here is another patient. This was a methamphetamine abuser, had meth mouth is what we call them back in the cornfields of Iowa, which means many teeth were abscessed. Fever, swollen neck, can't swallow, shortness of breath, underwent emergent tracheostomy. Now here's sublingual space, submandibular space, even back here getting into the carotid space, and here you see even some phlegmon in the retropharyngeal space. So not abscess, just phlegmon. Lemire syndrome is an interesting syndrome. It's actually refers to septic thrombitis of the internal jugular vein, typically following tonsillitis. The bug is Fusobacteria necrophorum. People have toxic, are toxic, have febrile, toxic and febrile, and usually a week following tonsillitis. Neck tenderness, respiratory distress because of the associated septic pulmonary emboli. There can also be septic emboli to the brain, the kidney, the liver, other organs, bones, even joints. Okay, so you must be aware this is a very serious disease with high mortality. So here's a 23 female, sore throats, fevers, peritonsillar abscess, failed azithromycin pack twice, came in with O2 sats at 80, blood cultures showed Fusobacterium nucleatum. Here you see that thrombosis of the internal jugular vein, clotted between here and here, and she had chest tubes and was intubated and put on multiple drugs because this is what her chest CT looked like. Terrible. But 3 months later, she came back. The PTA is gone. The chest is cleared up. The only thing that's left is thrombosis of the internal jugular vein, and you can live with that. But this person was not as fortunate. This one is 23, juvenile diabetes, end-stage renal disease, encephalopathic with respiratory failure. So here, of course, you see thrombosis of the internal jugular vein. You can see it coming down the neck here. Right there is where the clot starts and stops. And this chest x-ray just shows a couple septic infarcts here. Okay, you can see a few areas, but a couple days later, this is what the portable chest film looked like, and this is what the diffusion-weighted imaging of the brain looked like with multiple septic infarcts in the brain, okay, and she did not recover neurologic status, remained in a vegetative state, remained trached and transferred to another facility. So finally, necrotizing fasciitis, which is multi-compartmental, usually due to beta hemolytic strep. It's a not well-defined abscess with a capsule. It kind of goes everywhere. It's multispatial. And airway compromise can be an early complication with head and neck infection. So 25, multiple abscesses, status post-extraction. now dysphagia, difficulty breathing, and he was a Class A, which is highest priority, to the OR for incision and drainage. So here are these gas pockets all over the neck. In addition to the superficial area, you have them in the retropharyngeal space and even down here in the mediastinum. Another patient, also a drug abuser. This necrotizing fasciitis is predominantly on the right, and it's also continuous with a chest empyema. And don't forget the sinuses. I just want to show you acute sphenoid sinusitis and posterior ethmoid with an epidural abscess and an abscess down in the masticator space. Acute sphenoid sinusitis, thrombus in the superior ophthalmic vein. You see that. You go back and you look at the cavernous sinus. There is cavernous sinus thrombosis. Frontal osteomyelitis, Pott's puffy tumor from frontal abscess. And you can see it's not gone into the brain versus this patient. Big air fluid level in the frontal sinus, and you can see on the MR that there is meningeal enhancement and there is abnormal fluid and edema in the adjacent gyri in the brain. And then finally this one, clearly sinusitis with an intracerebral abscess. You have this ethmoid mucopyocele and a left frontal lobe abscess. So we've covered the things I hope to cover. I'm over about 30 seconds. I apologize, but I thank you very much for your attention. Thank you.
Thank you so much, Wendy. That was really terrific. Is Dr. Talley here yet? He actually does have slides here. He's traveling from Turkey. It's possible a colleague loaded them for him. But he's not here. So what I'd like to, I'm going to give the audience two possibilities. One is you can bail and go to dinner quickly. The other is, since we're trying to keep this appropriate for our CME timing and so forth, what we might do is something that's akin to the movie Airplane. If you've seen that movie where Robert Hayes is a former military pilot on a commercial jet, and he's called upon to come to the cockpit and land the jet without any particular training. That's sort of the analogy here. It could be humorous, but I'd like to at least walk through. I've seen Dr. Talley give this talk years ago, and I think as a group we can do an executive summary making some key points. So don't know what else to do. Feel free if you'd like to join friends for dinner. Otherwise, I'll try to take you through, and I do lecture on this topic myself sometimes, so I'll try to make some points as best I can and skip along because I don't know what slides are about to appear. Prevalence of infections is increasing, and it's still a major problem worldwide. The key points that Dr. Talley has here, that CNS is poorly compliant to acute infections, so this is a real emergency, and that is a key point, that infection can kill people in minutes to hours, so as radiologists we need to have a high index of suspicion. Now, we also know that early recognition, on the other hand, can actually improve outcomes in these patients. So the emergency steps, of course, patients arriving in the emergency room are evaluated, cultured typically if there's a concern for sepsis, and then imaging is done quickly thereafter. Ultimately, the diagnosis of meningitis is not an imaging diagnosis. A positive or negative study doesn't rule in or rule out meningitis. A lumbar puncture does. But the imaging is critical to help refine the diagnosis, to evaluate for complications, and to triage the patient for that potential lumbar puncture to make sure there isn't mass effect that could result in herniation. Now, meningitis is a condition of the leptomeninges typically, so this cloudy appearance that we're seeing here are white blood cells infiltrating along the leptomeningeal spaces. They're surrounding the arteries and veins, and this is one of the problems with meningitis. It isn't so much that it's necessarily directly infecting the brain, but it's this superficial inflammatory response which leads to venous thrombosis or thrombophlebitis, as well as arteritis, and we can have secondary injury to the brain, as well as a host of chemical mediators that cause damage to the CNS, ultimately leading to death. So there are two major patterns of meningeal enhancement. When we talk about meningitis, theoretically you could be talking about either of these, but for the most part I think it's most appropriate to talk about a leptomeningeal pattern, one that goes along and into the sulci, that follows the leptomeningeal spaces, it surrounds the vessels, and that's why we get these secondary injuries. Now, dural enhancement, which follows the inner table of the skull, can be seen with some infections, particularly viral, can be seen as a later complication, and in children, especially with things like H-flu meningitis, you may see more dural pattern. But for the most part, this is a nonspecific pattern, the dural part, whereas the Peel subarachnoid pattern is one that's highly suspicious for meningitis, blood pus or cells, as we say, so that's going to be your differential, subarachnoid hemorrhage, infection, or some other cells like neoplastic conditions. Lots of things can cause infection, as we know. Depends on the age, and we'll go through some key points here. Meningitis is the most common cause of cerebrovascular disease in children, and that's because so many of the streptococcal organisms do incite an arteritis. The diagnosis, again, is a combination of clinical and radiologic testing, but ultimately CSF analysis, or perhaps sometimes we can get the bug out of the blood. Now, in terms of the clinical signs and symptoms, I was a neurologist before I was a radiologist, so I feel comfortable with this. We have the classic signs, the Brodzinski sign and the Koenig sign. Brodzinski's where we manipulate and bend forward the neck, so B for bend on the neck, and we get a flexion at the knees. Koenig, you manipulate the knee, and you have the secondary response there. Either are essentially stretching the meninges and giving us a sign that there is meningeal irritation, and clinically then that, of course, would lead to further evaluation. So CSF analysis should be performed carefully, but I think on the balance, it's been shown that the risk of herniation, even in the presence of brain infection, swelling, is probably very, very small, whereas the risk of not making the diagnosis is very, very large. So on the balance, I think doing a lumbar puncture with a small needle is recommended if there's any doubt whatsoever. We'll skip over the CSF analysis, except to say that these days a number of PCR tests have been developed for things beyond herpes simplex virus. You can see some of them listed here. And there are other acute phase reactant tests that you can do as well. Now, imaging studies do play a pivotal role in the early diagnosis, although it should always be clinical. CT has its limitation, whereas MR, particularly supplemented by contrast-enhanced T2 flare images, can be quite helpful in defining the extent of meningeal irritation. And it's one reason why in our practice in Madison, we get our T2 flares routinely post-contrast. If contrast is given, we always just do the T2 flare in the first post-contrast position, then go on to the T1. It serves as a nice complement to the T1, and it's for this reason that we like to have it in there for infection. And because the contrast-enhanced T2 flare is better than a contrast-enhanced T1 or gradient echo particularly. We supplement that with the usual sequences like diffusion and all of your favorites. Let's see what we've got for some cases here. This is pre and post contrast. This is a gradient echo to show you that it looks like the meninges can be quite bright even on a non-contrast. When you give contrast, bending on the echo time and so forth, you can see greater or lesser enhancement. And you have to be a little bit careful, particularly at 3T, if you're using inversion recovery prepped sequences. The white matter can be so bright you may not see enhancement. So the complementary nature of T1 inversion recovery and T2 flare with contrast can be helpful. Now, let's see what we've got for meningeal enhancement patterns here. Here we have, it looks like a non-contrast T2 flare to me, and you can see even without contrast that, again, blood, pus, or cells will not suppress on a fluid attenuated inversion recovery sequence. You may sometimes see fluid levels, debris levels from cells dependently settling due to ventriculitis. Here with contrast, we more readily recognize, in this case, now the leptomeningeal enhancement surrounding the mesencephalon and the occipital cortices. But look how much easier it is to see this when we look at the pre- and post-contrast T2 flare. So now we did see some signs subtly, but we can really appreciate the meningeal enhancement on a contrast-enhanced flare. This is probably due to a couple of reasons. One is that the T2 flare, when you think about it, really has a number of different contrast mechanisms. It's nominally T2 weighted. It's also fluid suppressed, but it has characteristics to give you bright signal when there's very bright T2 species, but also there's some T1 shortening which can shine through, particularly in your 3 Tesla scans. So complex mechanisms of tissue contrast, but the intravenous gadolinium contrast does show up bright in the leptomeninges and also bright for most intraaxial lesions, as it turns out, things like tumors. Here are some more examples of illustrating contrast-enhanced T2 flare versus T1. In this case, it's that dural pattern of enhancement. Again, this is relatively nonspecific, not as specific as that subarachnoid leptomeningeal enhancement. You'll see this with low pressure situations as a delayed effect after craniotomies and other conditions. In the context of infection, you will sometimes see this as a reactive secondary effect after an infection, particularly viral infections. Now, I'm going to go back to that slide because I think there's a key point here for sure, and that is that one of the things we need to remember in reading emergency cases is on that non-contrast CT in a patient with mental status change. Even the slightest rounding of those ventricles, third ventricle, the temporal tips, you have to think infection. That's something that can kill someone if you don't suggest this could be a meningitis, an early communicating hydrocephalus. Meningeal enhancement, if you got it, of course, is a more direct sign. But just remember, communicating hydrocephalus in the emergency room, rule out meningitis and rule out a missed subarachnoid hemorrhage. Those are 2 things that can be a make or break diagnosis. Here we can also see sometimes how difficult it is to pick up meningeal processes, especially on non-contrast. Here, the rule that the left side of the brain should look like the right, which is the first rule I was taught when I sat down in a chair for radiology residency, is broken. These are obviously very asymmetrical. So the question is this swelling from the inside out? Is there an isodense subdural or something? Or is something filling the leptomeninges in an isodense kind of way? And so in the context of infection, we would then add contrast, and here we can now more directly see the enhancement. Again, you have polymorphonuclear leukocytes in here. They're going to pick up contrast. They're going to be weepy, and so you'll have not only the physical cells changing the density on CT or losing the fluid suppression on T2 flare, and then the more direct enhancement that we've talked about already. In some cases, you'll also see involvement of the ventricles and non-suppression of a T2 flare. That might be an example here. And here we also have some superficial enhancement of the leptomeninges with a filling defect. And remember, you may have cortical vein thrombosis as a secondary complication, which can lead to ischemic changes in the brain. So combinations of unusual regional ischemia, arterial or venous, should also bring to mind the possibility of a local infection causing that ischemic change. Here we have another nice example, I think, of the loss of fluid suppression. These sulci should all be dark. Instead, they're bright. So that's our leptomeningeal pattern. It may or may not be accompanied by a communicating hydrocephalus. In this case, that was absent, but this is still suspicious enough to consider the possibility of meningitis. Again, a nice example in the Sylvian fissure of focal leptomeningeal enhancement, finger-like extensions along the Sylvian fissure, in this case without too much edema around it. There are certain bugs that like this area. Tuberculosis, for example, loves to start as a little subpeel bleb and then rupture into the sylvian fissure. So depending on the demographics and your local exposure, that may be a strong consideration. Now, another thing that happens with infection is illustrated here. We can have subdural collections or even epidural collections, but typically subdural, quote, metastatic infections, sometimes from a sinus infection. These will be loculated. They tend to rim enhance, and let's see if we have any diffusion sequences. Here in another case, it looks like we have some T2s and diffusion, thank you, where we can see diffusion restriction in this subdural collection, and that confirms that this is infection. Why does diffusion show bright signal and true restriction when you work through the ADC? It actually correlates very strongly with the white blood cell count of the pus. So it's interesting that the cellularity of a pus pocket leads to this diffusion restriction. So you'll see in other cases, like those H-flu meningitis cases I alluded to earlier, you may have benign reactive subdural effusion. That's not going to be restricted on diffusion. So a key point here is when you have a subdural collection in the setting of infection, that the diffusion sequence is absolutely key in determining whether this is actually pus like this or just a reactive effusion, which would not be restricted. Certain organisms will lead to a so-called soap bubble appearance, and we can see nodular or soapy appearances with things like tuberculosis and cysticercosis, of course. Not sure what, this is cryptococcal meningitis, another good one. Cryptococcal meningitis loves the basilar meninges. In fact, when you see a basal process, it could be any of the major bacterial, fungal, or viral organisms. But when you see it going along perivascular spaces or forming little cysts, gelatinous pseudocysts, that's when we need to think about cryptococcus. Hypointense nodules, this sort of nodular appearance is typically seen with things like tuberculosis, and I guess I got that one right, so that's good. And you'll see this as a very common pattern with TB meningitis. That was an interesting case. Sarcoid can be a fooler, particularly loves the area around the optic chiasm. Sarcoid is one of those great mimickers that can affect the dura, the leptomeninges, can be a parenchymal lesion, can be associated with white matter lesions, but it's going to be on your differential for that nodular sort of base of brain appearance. You may see these little nodules hanging off cranial nerves, sort of like little dingle balls that might remind you of sort of a carcinomatous meningitis type pattern. But keep this one tucked away for that basilar meningitic nodular pattern. All right, this is moving on to viral infections. These sometimes have characteristic involvement on diffusion, which I think can be quite helpful. There's often a sort of a two-part sort of leading edge of diffusion restriction, and then as the disease process goes forward, more of a vasogenic reactive pattern. You'll see this with things like neonatal herpes simplex infection, a different pattern than what you see in the adults, more regional areas. You also see this with things like listeria meningitis. And as we move forward in this unfortunate case, don't know the organism here, we develop a cystic encephalomalacia. And this happens, unfortunately, even sometimes with rapid treatment for these diseases. Now, it shouldn't surprise you that perfusion can be abnormal in infection. Again, the leptomeninges are the site of the main pathology, and a lot of inflammatory mediators are surrounding arteries and veins, so you can have secondary ischemia. It follows then that in those areas you can have regional areas of oligemia. In fact, several years ago we did a little study of cases of meningitis and found that 75 or 80% have regional perfusion defects correlating to that leptomeningeal involvement. And another key point that Dr. Tolley would make if he were here, no imaging features distinguish from other meningitis, and that's true. I think in general it's going to be a differential, and another key point is that negative imaging does not exclude meningitis. It's always going to be a clinical diagnosis. So let's call that an executive summary on the fly. I hope it was useful to you and that you had a few take-home points there. We appreciate your attention at the end of the day, and I apologize you didn't get to hear the real expert give the real talk, but thank you very much for your attention.